Good morning and warm welcome to Online Anaesthesia, an Anaesthesia update on Zoom platform, sponsored by Akula and hosted by A1 Logics, and our media partner is Anaesthesia TV. In today's Online Anaesthesia, we have two practical topics. One is from Dr. Parthasarathi. He is going to deliver a lecture on the perioperative anemia, the management strategies, and followed by Dr. Pankaj Kundra sir. He is going to deliver a lecture on the dilemma in the perioperative assessment of children. Both speakers are well known to our audience. Today's session is moderated by Professor Kannan sir. He is a former professor and HOD of Tirunelveli Medical College, and he is a professor emeritus of Tamil Nadu MGR Medical University. He is editorial board member of IJA, and he is a former General Council, Governing Council member of ISA National. Over to you, sir.
Good morning, everybody. I thank the Online Anaesthesia and Professor Edward Johnson for giving me this opportunity to chair this session. And Dr. Parthasarathi is a well-known senior anesthesiologist in our area, and he has completed his MBBS in 1985, and he acquired his MD and DA from JIPMER, and also a DNB from JIPMER. He is also a doctorate in physiology from Shillong University. And at present, he is a consultant anesthesiologist and, of course, in the cadre of professor in Mahatma Gandhi Medical College at Pondicherry. He is now going to enlighten us with some facts about the anemia, perioperative management of anemia patients. You know very well, anemia is something like an endemic disease in our population, especially in girls in the reproductive age group, and also in children, and also in elderly people where the nutritional anemia is the predominant factor. And many of these patients comes to us for elective and as well as urgent and emergency surgery. How to manage these people? Of course, we know without hemoglobin, oxygen cannot be delivered to the tissues. So how to improve the hemoglobin, how to take up these patients for anesthesia and surgery? We will hear from Dr. Parthasarathi. Over to Parthasarathi, please.
Good morning and welcome to this online CME. I wish to thank Professor Edward Johnson and my teacher, Professor Kundra, on this occasion of this CME. Good morning, everyone. Today's talk is about perioperative anemia, management strategies. This is the topic given to me. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar. So this is our college institute and our theater and our machine. So when I go and to see the internet and the books for this management strategies of perioperative anemia, I can see innumerable guidelines. This is 2016 guidelines. This is Turkish guidelines. This is European guidelines. This is so many guidelines are there so that we can do only this. After reading this, we have to go into this stage. So, why was the topic given by doctors? Why should we know about this topic, perioperative anemia management strategies? Now, here you see, if the patient is 18 years old and is having moderate anemia, there is an increased chance of postoperative blood transfusion and there is some risk of death. So, if there is a preoperative anemia, there is an increased chance of transfusion, increased risk of death. This is one of the reasons that we need to understand what is perioperative anemia. Now you see here, in cardiac surgeries, in gastric cancer surgeries, everything outcome depends upon your hemoglobin levels. Also, this plays a major role here. Hence, we need to know about this anemia and today's importance of this topic. See, many husbands are like this. So our anemia is not like this. It's not an innocent bystander. It worsens cardiac illness. It worsens renal failure. It increases hospital stay, thereby the cost. Now, what they call is patient blood management, PBM. What is this? It's a multidisciplinary. No, it is not only anesthesia, surgery, anesthesia, medicine, transfusion medicine, hematology. It's multimodal. So you cannot give only iron oral. It may be iron supplemental, intravenous also, blood also, homogeneous blood, allogenous blood, so many things. Patient-centered strategy. What is the patient like? How is the patient? Aimed at minimizing the use of blood products. Lot of blood products should not be there, but patient's outcome should be good. This is what is called patient blood management. So I'm not going to go so much into theory now. Whatever I want to tell today is about some experience, some book and some journal like that. So we will go to pre-operative anemia, intraoperative anemia and post-operative anemia. So these three things are actually combined as perioperative. Now pre-operative anemia, if you go into the guidelines, they say 12 for females and 13 for males. There is also a strong objection to this. Why should females be less than 12 and why should males be less than 13? Both are equal. Something like that is happening in UK also. So 12, but Indian is 10. Mild here is 8 to 10. So what we have is around 7 to 8 is moderate, around 7 is severe, and 8 to 10 is mild, or 10 is normal. Many of these things talk about non-pregnant patients only. So pregnant patients, scenario is different. What is the incidence of preoperative anemia? If you take it as 13, no, almost all 75% of our patients will be anemic. And if we take it even as 10, 1/3 of our patients, preoperative patients, are anemic. That is what the evidence tells. If we take it even as 10, 1/3 of the patients are anemic. Now I have already told cardiac mortality increases, transmission of blood and transmission of blood increases, thereby the transmission of illness, cardiac illness worsens because the cardiac output increases, the SVR decreases, the oxygen delivery decreases. So increased oxygen extraction by the skeletal muscles. But in brain and heart already it is fully extracted. Because there is some anemia, it cannot extract more. This problem is there. In the setting of hypoxia, in the setting of shivering, and in the setting of pain. 1, 2, 3. These are very common in the perioperative period. In the setting of hypoxia, in the setting of shivering, in the setting of pain, we have some problem with oxygen delivery. This is what we don't want. Why should anemia occur? Anemia can occur because of bleeding, inflammation, nutritious, chemotherapy, and drugs. This is not a classical hematology De-Croce definition. This definition is more towards the conceptive etiological focus on the perioperative period. Now you see acute bleeding, rupture ectopic, placenta previa, trauma. All these things we cannot say the hemoglobin is 6. Boss, I'm not taking up the case. We have to take up all these things. Chronic is a GI bleeding if they are going for endoscopy or if they are going for some other procedure. A DUB, a colonic polyp. See, for example, in DUB, they may go for fractional curettage. The hemoglobin will be around 8 or 9. Okay. Now you give blood. What happens at the time the next period comes, the cycle comes, she will bleed whatever you have given already. So it is some sort of semi-emergencies. So we cannot go and make unfit every patient. Or this may be a possible malignancy. If they do a fractional curettage, they may detect a malignancy in 2 days. But if you give iron for 8 weeks and then take up the case of hemoglobin picking up from 8 to 9, then 45 days to 50 days of malignancy is lost. That we have to think and then give fitness in time. Now, we have one more thing. This is the normal uterus. We have a myoma bigger than the uterus. This myoma bigger than the uterus needs to be taken out. because if the next bleed, it will bleed another 500 ml. So this has to be taken out. So whenever you see PAC, hysterectomy, myomectomy, see the size of the myoma, and then see hemoglobin, then correlate well, talk to the surgeons, and then make the case fit. Now we have chronic inflammation, rheumatoid arthritis, CRF. Rheumatoid arthritis unlikely to become more than 10. CRF unlikely to become more than 9. There are two more interesting cases in the preoperative period which we commonly come across is myocele and Fournier's gangrene. These two patients will not have high hemoglobin levels. Hemoglobin will be moderately or mildly anemic only these cases. Because of this, we cannot make the patient unfit. So this has to be kept in mind. Anemia may be an associated thing in this. It will take long time to pick up this hemoglobin because the sepsis will cause this problem. So we may need to do the surgery and then treat the anemia. Chemotherapy, myelosuppressive drugs, radiotherapy, and erythropoiesis. All these things are problematic. You cannot have hemoglobin of, for example, heparin, gatons, clopidogrel. So many drugs can cause problems with hemoglobins. Now we have iron. There may be problem in absorption or there may be bad diet. So the ideal drug which we use is ferric carboxymaltose. We give usually 500 milligram, one dose, followed by next week one dose, or sometimes followed by oral iron, vitamin B12 and folate tablets. So the pickup we can wait for 8 to 12 weeks or 4 weeks after parental iron. So 4 weeks, if you give 2 doses followed by oral folate and B12, yes, parental iron pickup. Elective case, is it okay? Most of these patients, we need to investigate anemia. That is very important. Take a peripheral smear. See also the platelets. See also the total count. See an expert opinion. So we may need to basically test all these things. Yes, we can also go ahead with testing in patients with microcytic hypochromic anemia, possibly transferrin levels and all these things. But be specific in taking an ultrasound abdomen because there may be splenomegaly. If you have splenomegaly, your hemoglobin is unlikely to go up 10. So it is a destructor of RBCs. You get some sort of pancytopenia. So take up these patients. You cannot increase the hemoglobin by giving iron alone. Pick up the case, get the splenectomy done, and then whatever is the ideal thing, compromise there. You have to go for prothrombin type. It is very important. So these are all the basic investigations for identification of cause of the anemia. Yes, preoperatively, we need to work up on the cause of the anemia. It is a chronic inflammation. I already told CRF, rheumatoid arthritis, usually parental anesthesia. Myelosuppressive drugs, we cannot go. As for example, the patient is a myelosuppressive drugs or some CML, chronic myeloid leukemia, and the patient develops humerus fracture. It's not a pathological fracture. It develops a humerus fracture. So how long will we wait now? We can give iron, blood, and all these things all, and wait for 6 weeks or 8 weeks, something like that. There we have to decide on other transfusion if the patient is anemic. Yes, if it is going to be more than 10% of blood volume loss, if you expect in a surgery, think of blood transfusion. Think of. If you expect 10% of blood volume loss, beware, take it out. Be ready with some other things. So 10 and 20%. This is not applicable to pediatrics. This is about adults. Now we have decided to give blood. Yes, this is the patient which needs blood. Autologous blood can be collected from 5 weeks to 3 days before elective surgery. Take the blood from the patient itself some 3 to 4 weeks prior and start giving intravenous iron, folic acid, B12, everything. So this will pick up by 1 gram in 3 weeks. So this will be okay. And then give the blood during the surgery. What is acute normovolumic hemodilution? I'm not going to the details of these things because it's a different topic, blood conservation strategies. You get the patient on the day of surgery, remove blood and give crystalloids 3 times and then use it after the surgery. What is the basic purpose is, now you have taken out 350 ml and you have given 1 liter. Now the 1 liter is diluted. your whole blood. Now, if the patient bleeds 350 ml, now you see there is some RL also is bleeding. Your ringer lactate also is coming out. So we have got a better RBC level after the bleeding. Anemia less than 8 grams. Yes, consider preoperative transfusion. Preferable to increase up to 10 in elective cases. By which way? Preoperative workup for the cause 4 to 6 weeks prior, ideally. Now, we have a lot of, yes, we give blood. Okay. Now, what are the problems? There is an infection transmission, transfusion related acute lung injuries. But now, recent techniques and different evolution of this blood has come possibly towards safer blood. But if you have a low hemoglobin and if you want urgent surgery and if the patient is hemodynamically unstable, think of others' blood. Now, I already told in certain patients of CRF, what I do is I give 40 mg of darbepoetin alpha. This is an erythropoietin stimulating factor. So, I give 40 milligrams and iron folic acid. I usually give naso-B12 because if you pump this, B12 is not very good in absorption. If you give prick every day, the patient may not be very happy. So I use naso-B12, 2 drops, 1 drop each in this nostril every day. It is fine. Iron folic acid supplement along with this, we can expect a pickup of 2 grams in 3 weeks. So this is best even for chronic inflammation. Even for malignancies, give an erythropoietin stimulation, give iron folic acid, naso-B12, pick up the hemoglobin by 1 gram or 2 grams, then ready. You're 3 weeks only, it's not a big time. Now, what I want to tell is ectopic, yes, go ahead with surgeries. Bleeding hemorrhoids, very clinical condition. Common clinical condition, you will get hemorrhoids. If your hemoglobin is 8.5, what are you going to do? If your hemoglobin is 8.5, you are going to give iron, folic acid, B12, nasal, all these things and pick up to 9.5. The next time it bleeds, again it will come back to 8.5. That is where, if there is a hemodynamic instability, if there is an urgent surgery, if the hemoglobin is less than 7, then you go for blood and do. If it is more than 8, then do the surgery, do a post-op hemoglobin, see for all these things, and then give blood if it is necessary. Sepsis, autoimmune serum. Yes, I always prefer to keep a hand on pulse. We are all old timers. You new timers have started seeing all these lab investigations and all. We used to put a hand on pulse. If a hand on pulse is not showing tachycardia, if it is not showing a bounding pulse, and if the BP is not showing 150 by 60, these are all things which patients tells that the patient is significantly anemic. And if there is no tachycardia, so all these things make tachycardia means there is some volume loss. High systolic, low diastolic means anemia is compensated by SVR reduction. So all these things make you think that this patient is anemic. Now we have got all psychiatric patients coming for hemoglobin with 9. Now can we give a patient of schizophrenia iron tablet and folic acid tablet and give after 8 weeks, come after 8 weeks? This is not possible. So we have to decide on case-to-case basis there. Can he take the drugs? He will not take even anti-epileptics. He will not take even antipsychotics. He will give the drug to his relative, his uncle or something else. You are only having psychiatric illness. Something you will tell. Now, if the psychiatrist thinks that ECT is going to correct his food habits, give an ECT with 8.5 grams if the patient is otherwise okay. And then starts, if he gets okay, then starts giving iron, pick up the things. There are few more instances. You have long bones fracture. You have a fracture of femur. You have seen the pack. You have seen the day before. Okay. Now, what they will do is on the night before surgery, they will clean the hair and all these things. They will betadine scrub and this movement of the fracture site will cause bleeding. So the next day you have to assess again. The previous hemoglobin will be around 9. The next day it may be 8.5. See the pulse rate, see the area, you see the tongue, see all these things to get the idea there is no blood loss excess, and our hemoglobin of previous recorded 9.5 is acceptable. Now, this is our study assessment. This is about pregnant patients. If you can see here, our pregnant patients less than 10 is 50% around. And the guideline says 13 is around 2.9. So that is why I told so many guidelines, so many heroines, so many things are there. It's very difficult to take up all those guidelines. Personally, very difficult to adopt those guidelines in our setup. See, this is the preoperative screening. Blood is not an option. Multidisciplinary approach, optimized coagulation, adequate nutrition, B12, folate, etc. ESA use. This is what I told Darbafighting. Now we know the hemoglobin is less than 8, and if the patient is having urgent with hemodynamic compromise, you have to give blood. If the patient's hemoglobin is more than 10, yes, okay. If the patient hemoglobin is between 8 to 10 or something, 8.5 or something like that, then wait with iron if there is a non-urgent surgery. This is how we need to proceed, because we know preoperative anemia is likely to cause more mortality, more likely to cause cardiac illness, more likely to cause renal illness. Get it up. This is what is the preoperative strategy. Now we go to the intraoperative strategy. Yes, decrease the blood loss by way of so much. This is now it's coming microprocessor control. Talk with the surgeon whether he is using tourniquet, because sometimes there will be fracture in the lower humerus. Lower humerus fracture, some surgeon will do with tourniquet, some surgeon will not do with tourniquet, because after tourniquet there may not be any place to put the knife. Talk with the surgeon about the blood loss, with the correct surgeon. Many times what we do in institutions, we talk with second year PG. We talk with second year PG, he'll say, no, blood loss will not be much. Then after that, the surgeon, original surgeon who is going to operate comes, no, the position is lateral and the blood loss is high. I cannot put tourniquet and all. So talk with the surgeon means talk with the surgeon who is going to operate. Hypotensive anesthesia, Viagra. Everyone knows Viagra, I think. But many of people don't know hypotensive anesthesia. Vasodilators, inhalational agents and IV anesthetics, adrenergic blockers, ganglion blockers. Geography means position change. Regional anesthesia is likely to cause less blood loss. Airway pressure and PEEP. Once I will tell, one of the SRs was doing some surgery here, big surgery, major surgery here. And the SR has put the tube of 7 size tube for an adult male. Because it was a difficult airway, at all we put a 7 size tube. And there was a lot of bleeding. Lot of work. They took long time. And so what happened was, we kept the tube because there was lot of tissue dissection and all these things in this area. So we kept the tube in the post-operative period. And Dr. Ravi Shankar came and simply he said, remove the tube. We took out the tube. Then he told that because of your low small size tube, you have created a pressure inside high, and that is was causing oozing here. All was iatrogenic because of the anesthesia. So there was surgery was fine. Because the tube was removed immediately in the post-operative period, airway pressure became normal, bleeding stopped. So this has to be kept in mind. So I always give hypotensive anesthesia is a different topic. I always give beta blocker in any patients. I give 40 milligram of beta blocker for pronolol, because what is necessary is hypotensive anesthesia. If you start, there will be sympathetic surge. This sympathetic surge will kill the aim of your hypotensive anesthesia. So start at the low dose beta blocker, 40 milligram, 1 hour before or 2 hours before surgery. Then you do this. Your hypotensive anesthesia will work well. Viagra will work well. That's what I told about geography. In thyroid patients, you just lift up the head like this. Your jugular is going to drain fast. Your pressure here is going to be less. Your bleeding is less. Similarly, like this, your intrathoracic pressure is likely to be less. There are a lot of things. Intraoperative cell salvage techniques. Here, wound circulation, again put it back. Long time ago, when I started practice in 1995, 96, what we do in ectopics, where we will just, the staff nurse will take out the blood and there will be 8 gauze pieces. and there will be a bottle, old glass dextrose bottle, which is again sterilized, again kept like this. They will make into the glass pieces, blood will, the filter is 8 sets of glass pieces, and we will give it back again. This was the first thing which I saw in 96, intraoperative cell salvage technique, and this is beautifully becoming more scientific and better suited for less side effects. This is what we have given hundreds of blood transfusion like this long back, but now it is not possible, and we have to have an official approved guidance based cell salvage techniques. Very important, we always neglect this. We get the OT temperature to 26, 28 and patient temperature to 33, 34, 35 and all. A normal prostate operation. See the temperature, and because the water is flowing here and water is flowing from there also back, so bleeding will be more. So they are told 1 degree C, bleeding is 16% more. So get the temperature to 36. Don't keep it like this. Get the temperature to 36. It's a very simple technique of intraoperative anemia management. There are fluid warmers and there are body warmers. Now there are certain surgeries which we will not know. For example, a priming solution in cardiac cases. That I am not going into the detail of this. If your 1.5 liters of priming solution enters the circulation after you are starting your cardiac case, then see of this anemia. That is why in sick patients, in pediatric patients, they start with blood priming. Bone grafts. If you take a bone graft, they will suture it and put a big plaster. We don't know how much it oozes. Split skin graft, they'll pick up big things. So whenever your patient is posted for SSG, ask the surgeon what is the area, because many times it is completely rounded. We may not know which is the area to be grafted and which is the area from which they are going to take the graft. Then they will tell, I'm going to take from the right side also, left side also, because the wound is big. Then as soon as you, there will be oozing. After you are taking and fixing, continuously oozing, 100 ml every 5 minutes will correct sometimes. So keep in mind these things. Tonsil, nasal surgeries, because these things will be swallowed by the patient, and after he vomits only we will know he has already lost 400 ml of blood. After he vomits only we will know, otherwise he will not know. There are a lot of drugs. 29Oct alpha, Sukotov alpha, I don't know whether they are English or not, Adnexan alpha, Argotraban, all these things. But what we know is this. We know tranexamic acid infusions. We know adrenal infiltration in acceptable cases. We know vasopressin in mammectomies. It is a short-acting vasopressin. But after between this, in this time, we should all suture it, get the arteries, get the feeder vessels tied. We are safe. So these are the 3 important drugs which are helpful in management of intraoperative anemia. Beware of ketorolac, because this prostate and tonsil, they depend upon your natural coagulant mechanisms. We cannot go on prostate so many times tie it off. Yes, we do that. In tonsil also there may not be. So 1 or 2 things we will cauterize. But sometimes, many times, we need a natural coagulation mechanism to work in PACA for any type of post-op bleeding to be decreased. So beware of NSAIDs in these patients. Use of diathermy has completely revolutionized your blood transfusions. Internal iliac artery ligation in placenta previa. That is what now I give an idea to my physician. There is a placenta previa. Start as soon as you deliver, just clamp the internal iliac and then do your hysterectomy or whatever it is, or placenta removal or whatever it is. Then after everything is fine, you can remove these internal iliac arteries and see what is clamp. Remove the clamps and see. If there is any problem, you can clamp it again and tie it. In sick anemic cases, first tie the clamp at least the uterine arteries, then proceed with hysterectomies. There are a lot of vessel sealers and vaginal hysterectomies, so the bleeding is very minimal now. So these are certain small things which makes intraoperative anemia strategy very simple. This is a non-virgin clavicle. You see, I have done this case. Non-virgin means already clavicle is broken. broken, plate is kept. Now the plate is broken. Now, if you touch it, there will be extreme blood loss. There is no tourniquet here. So that is a problem. So here, if there is a fracture, especially reopening humerus, there is no tourniquet. It is not virgin. We have already got some operation done. All these things, blood loss is maybe excessive. We should be careful. Especially when you have reaming. Because it will not, no, because they will ream, and where is the blood gone? It is not outside. Sometimes the BP falls. The blood loss is 300 ml in the reaming. Just again they will ream, another 200 ml will go off. Now, if you go and see now, that's what I told in the first. Start seeing so many journals will get confused. Acetabular fracture open repair, they say the acceptable or the estimated blood loss is from 100 ml to 2 liters, 50 ml to 1 liter. There is, we cannot take this as a guideline anymore, because the estimated blood loss is from 50 ml to 1000 ml, 25 ml to 100 ml, 25 ml to 500 ml. So we cannot take anything from here. We all know this MABL, EBV, HCT, initial minus target by initial. So what is the initial now? If we take 13 or 12 or whatever it is. Now what is the target? Some people say 8, some people say 9. Now this case is 8 or 9. Our institution puts only at 9. Sir. So this is the same for chronic inflammation. Is it the same for CRF patients? All these things are so many differences in guidelines are there. And it also changes with BMI. Now your blood volume, estimated blood volume may be 45 ml per kg for this and 65 ml per kg for this. So that has to be also taken into account. Now I asked one of the transfusion experts, why are you giving blood? Why are you giving packed red blood cells? He simply said, whole blood is not available. As soon as we take the blood, we will make it into components and we keep RBCs. And each RBC is expected to rise the circulating by 1 gram. 8, if you give 1 packet RBC, it will become 9. That's all. And more than 20% of the estimated blood loss. Again, volume. If your volume is 4 liters, estimated blood volume. If you have more than 800 ml, beware. This is the intraoperative strategy. You can see so many things here. Laboratory testing, cell salvage, autologous, permissive hypotension, excessive phlebotomy, all these things. But what is important is diathermy, suture, antifibrinolytic, tourniquet, normothermia. You can see all these things. Now we have an idea of about intraoperative salvage. Now we will go to postoperative salvage. Worsening of preoperative anemia, perioperative blood loss, intraoperatively coagulopathy and phlebotomies, and continuing postoperative blood loss in the drainage tube. Postoperative reduced erythropoiesis due to surgery. And sometimes, we will not know the amount of blood loss, especially in prosthetic surgeries. Prostate, there will be saline going on and the blood will be collected. We don't know how much is the blood loss. Because 5 liters of saline has gone in, the next day we have taken out this thing that is reddish and maybe 500 ml blood loss or 1 liter. So these has to be taken care of. What is the chemistry behind this? Inflammatory cytokines after surgery can lead to a cascade of effects. Epsilon increase. There is a problem. So iron is not available. Active inflammation, decreased iron intake from the externals. Erythropoietin is because of this inflammation. So all these things go into the preoperative hemoglobin, blood count, platelets, all these things. Who bothers about postoperative hemoglobin, platelets? Nobody. I have seen how many consultants go and see what is the postoperative hemoglobin? Very less. So we are not putting a blind eye towards postoperative iron, postoperative heparin when they are starting, post-operative, propylate, when they are starting, all these things, we get opinions and we don't know what is actually happening, and then land up in problems with bleeding and then retake all these things. So we have to go and to the post-operative ward, see the blood loss. Said yes, we can also give erythropoietin and start iron infusions in the post-operative period day 2. Nothing wrong. Yes, I have seen already gastric bypass surgeries. We have to go for parenteral. We cannot put something with the right tube aspiration on. So these are the things which we may need to have an open eye, not a blind eye like this, in patients in the post-operative period. We are more concerned with preoperatives. Avoid unnecessary phlebotomies. I can see their books say 40% of post-operative anemia are due to phlebotomy. What is the phlebotomy? Take blood, 15 ml, 20 ml, take culture, take all these things, blood culture, the culture, take LFT, RFT, CBC, coagulation profile daily. So beware. Is it needed? Think about it. And many times the CBC and RFT are not seen by the surgeons. Somebody else sees and sees those hemoglobin. So phlebotomies, LFT, RFT, LBC, not like this. Do an investigation, hemoglobin, preferably on day 2 or 3, where it will reflect the hemoglobin levels clearly. What is permissive anemia? The concept of permissive anemia is based on the principle that low post-op hemoglobin levels are well tolerated. Don't give. Little less hemoglobin is well tolerated in the post-operative period. So these are all the guidelines. Again, I see optimize hemoglobin recovery. Nobody uses post-operative erythropoietins at all. Folate, B12. So there are two things: liberal transfusion and restrictive transfusion. This liberal is around 9-10 you give transfusion. Restricted is around 7.5 to 8.5 only you give transfusions. These are all the complete guidelines. So what I want to tell is, what is pre-op anemia? That itself is a confusion, either 13 or 10. What are the causes? Treat the cause. And you cannot wait for treating the cause if the cause is going to be a bleeding piles or a DUB or anything like that. I have seen a case of an ovarian cyst coming to the preoperative clinic and rejected for anemia, and in the afternoon it came as ectopic, the same patient. So also this is possible. Look at the patient's pulse. Then you can give blood in cases of urgency, in cases of hemodynamic compromise, if the hemoglobin is very low, like less than 7. Intraoperatively, tourniquet or not. The drugs are not. Stop all drugs, clopidogrel, heparin, whatever the patient is getting, aspirin, whatever the drug according to the guidelines. Keep the position. Thyroid means simple. Keep the position. Talk to the surgeon. And what is the surgery? And what is the surgeon? Who is the surgeon? That also has to be found out. Post-operatively, see the drainage, lab test. Post-operatively, also we can use iron, darbepoetin, erythropoietins, and all. There may be some pressure to make patients fit. Yes, what we just give blood and take it up. You tell the surgeon, convince the surgeon. Yes, we can do the case after 3 weeks. It is only vaginal hysterectomy. Don't bother about it. Initially, the management, if you say, it is a cost-based strategy. Secondly, it becomes a case-based strategy. If you remove you, it becomes a case-based strategy. And it is preferable to have institutional guidelines of how to give blood and when to give blood perioperatively, or when to give iron, because many surgeons may not like your erythropoietin injection and come back again. So you have to have institutional guidelines for this. Make up a team of surgery, orthopedics, gynec, anesthesia, transfusion medicine, and a hematologist. Make up a team and give the guidelines like this. The guidelines are not for all cases. Yes, it's a case-based strategy. Just because it's telling something like that, a septic peritonitis is unlikely. A peritonitis can come with CRF. A sepsis of the wound can come with diabetes and CRF. That I cannot expect a hemoglobin of around more than 7. That should be made a case-based strategy. Thank you all. Thank you for patient listening. Visit my YouTube Pain-Free Partha and visit my website www.painfreepartha.com. Once again, I thank the organizing team for this wonderful.
Thank you, Parsadi. Can hear me?
Partha, please
You
come
can hear
online.
me? Yes.
Yes.
Thank you, Parsadi. The lecture is very nice, very informative, and very useful to all practicing anesthetists. I have few questions from the chat box. Dr. Edwin has raised the question. Is the guidelines are the same for cardiac patients with failure or without failure? Guidelines of 8 or 9 hemoglobin. Can you hear me, Pasadi? Yes.
Yes, sir. Yes.
The hemoglobin target is same for the non-cardiac patients also. Cardiac and non-cardiac.
Cardiac. Yes. Then, many a time we faces patient in a very short interval. So, perioperative transfusion is good or intraoperative? Because the textbooks used to say preoperative transfusion will be good rather than intraoperative. What is your opinion regarding?
It depends upon the case, sir. It depends upon the case. For example, the hemoglobin is 8 and hemodynamically unstable in a case of peritonitis or something like that. You give the blood and start the case. Or is it a different thing? For example, if your hemoglobin is 7 and your surgery is ectopic, then you need to clamp and then give blood.
And patients with antiplatelets, is it necessary to give platelet first and then the transfusion, or you can give simultaneously? There is one question from the chat box.
No, sir, it depends. Platelets and all is not considered for these patients on a clopidogrel. You have to stop clopidogrel, run the show, and see according to the guidelines of whatever be the blood loss, give the blood. Or blood components, RBCs and other things. It's not necessary that the patient is on clopidogrel, we should get pre-op clopidogrel, platelets and all. No.
Yes. Yes. Then, and one gentleman asked this question, liposuction, in liposuction, how to assess the blood loss? Because he found difficult to assess the blood loss, I believe, but I have not anesthetized patients for liposuction. I do not know. Do you have any methods or techniques?
The techniques remains the same, sir. The assessment blood techniques remain the same. We have to weigh. We have to weigh and differentiate things in grams. We have to weigh the section. The technique depends on just because we have not done renal transplant, we have not done big craniectomies and all. The basic technique of analyzing the blood loss by way of section, by way of pad, by way of weightage does not change.
Many a time, this is my question to you. Many a time, we face bleeding piles. That is a common one. They come with 6 grams or even 5 grams, and we have to do something. And we used to give under a saddle block. And many a time, this is questioned again by our junior postgraduates. When there is hypotension, then he makes a calculation and says the oxygen delivery is less. But anyhow, the patient goes on well. What is your opinion regarding?
I have already told. Hemodynamically unstable, urgent, and then only you should consider preoperative blood. Otherwise, if the patient is fine, then because the patient is bleeding, clamp and then give blood.
Yes, that's right. Any more questions, Dr. Edwin?
No, sir. So the question I asked is why the intraoperative or postoperative transfusion you prefer. Suppose we prefer intraoperative transfusion, the surgeon will say for 6 grams also you go for elective surgery with intraoperative transfusion. Why do we wait for hemoglobin to be corrected. So that's why I asked that question. That is pre-operative transfusion versus intraoperative transfusion. And there is one question, erythropoietin is indicated for all cases or only for CKD patients for correction of anemia?
It is also useful in chronic inflammation, not only CRF. It can have rheumatoid arthritis. Rheumatoid arthritis anemia, I use Darjan for 40 mg weekly and then 2 doses followed by oral iron, naso B12. And then because naso B12, injection B12 is very painful. So 2 drops of B12 and then start the case after 2 weeks.
So in the postoperative anemia, you talked about the postoperative anemia. So what is the ideal time to take up the hemoglobin in the immediate postoperative period?
2 days.
2 days. First. So the reason, you also tell the reason. The first day there will be a dilutional anemia.
Yes.
So you should not take the hemoglobin the first day. So there was one question related to that. And how long will it take the hemoglobin to go up after a transfusion? You said one packed RBC will raise the hemoglobin to.
As soon as the blood is given and the blood is completed, it will rise by 1 gram. Only the oxygen delivery may take some time.
Oh.
The volume is immediately restored.
Immediately.
Oxygenation is slightly delayed.
Okay. Kannan sir, that's all the questions. Also,
Yes.
sir, really touch the practical things.
Thank you.
Fulfill my expectations. So these are the practical questions we expect from the consultants. Thank you so much. Kannan sir.
Thank you, sir. Thank you, Dr. Pasadi. Now we will go to the next lecture. Shall we go to the next lecture?
Sir.
Next lecture is by Dr. Pankaj Kundra, and the topic is dilemmas in pediatric anesthesia. And Pankaj Kundra, everybody knows throughout India and in fact throughout world, anesthesiologists, they know him. And he requires no introduction. He is a professor, now the Dean of Chipmar Medical College. His awards are many. Lifetime Achievement Award by Indian Society of Anesthesiologists. And he has a lot of original work which has been awarded Best Paper Award in 2018 and 19. And academics work, he has published more than 7 or 8 original works, and he is a teacher for nearly 3 decades, and he is now holding administrative posts, and yes, number of 138 publications, and he has written 12 chapters in various books, and we are pleased to hear your lecture today, sir. Over to the lecture, please.
Shilpa. Unfortunately, Pankaj sir could not attend today's meeting because of the convocation in the JIPMER. He has sent the recorded video. We will play the video.
Johnson to have given this opportunity to me. The topic assigned to me is preoperative assessment in children, the dilemmas. Now, whenever we talk about preoperative examination or assessment, history and clinical examination play a crucial role. Even in children, there are some aspects which are generally missed. Apart from the brief history which we normally take for children, it's important to assess the other points like prematurity, congenital conditions, including family history, acquired conditions, development and behavioral needs, previous experience of surgery and anesthesia, anxiety issue and current status, immunizations and medications and allergies. Some of these points are generally missed when we look at children. So these also need to be emphasized and a detailed history needs to be taken. In general examination, apart from the other parameters which we record, it's important that we record the oxygen saturation and blood pressure of children when they are over 3 years. And ideally speaking, preoperative assessment in children should be done at least 2 weeks before procedure so that adequate preparation time is allowed and the surgery is not unduly postponed. Now let's come to the dilemmas which exist. The first one is a murmur. So if you happen to put a stethoscope onto a child and you hear a murmur, then we have to see whether this is an innocent murmur or is it likely to be a pathological one. If you find that there is a history of recurrent chest infections, history of feeding difficulties, cyanosis, tachypnea, sweating or failure to thrive, then it is possibly a pathological heart disease and you should be more careful in auscultating these children. The other aspects which can help you to diagnose a pathological murmur is if the patient or a child is syndromic, and if all those associations and syndromes are linked to the child, then you would probably have to assess him or her further, especially when the age of the child is less than 1 year. That means we'll have to go and further investigate doing an electrocardiogram or a 2D echocardiography. Now, what are the characteristics of a murmur which is innocent and pathological? The cardiac symptoms would be there or the child would be symptomatic if it is a pathological murmur. Looking at the timing, you'll find the pathological murmurs are generally diastolic. You will be able to feel a diastolic thrill at times, or pansystolic or late systolic, whereas innocent cardiac murmurs are early systolic or continuous like venous hum. The quality of the murmurs are variable and harsh when they are pathological, and they are rarely altered by posture. So if you consider these factors, you would be able to differentiate whether the murmur which you are listening to happens to be an innocent murmur or a pathological murmur. And in case it is pathological and most of the criteria satisfy it to be a pathological, then it's better to have a consultation done with a pediatrician or a cardiologist to confirm your findings. The second dilemma. The second dilemma is when a child presents to you with upper respiratory tract infection. Now, when we look at this child preoperatively, the broader points under which you will categorize is whether you can reschedule the surgery or you can continue with the surgery. So, how do we distinguish whether we should accept the patient or a child for anesthesia surgery or we should postpone? If the child has clear running nose, it's a minor surgery and it's only an occasional dry cough with no systemic manifestations or constitutional symptoms, then it is possible that you can accept the child for surgery. However, if the child is less than 1 year old, has chest signs, has history of asthma or hyperreactive airway, has purulent sputum and cough, which is productive, has purulent nasal discharge, is systemically unwell, has feeding problems, and the surgery is going to be major or an airway surgery, then it is better to postpone the child. And the postponement would be depending upon the severity from 2 to 6 weeks. I still have my reservations to say that an infant should be postponed. However, once we are doing a procedure, a child who's 9 months old or an infant which is 1 year or 2 months old would not be the one which would surpass our judgment whether the age should be the criteria. Hence, I've put it in black. You can reconsider according to the severity of symptoms that we should postpone or we should accept the child for anesthesia. Similarly, purulent nasal discharge can be there in many children, especially the children coming to us from the poor socioeconomic status. They may not have any other constitutional symptoms, but they would have chronic coryza or cough. They will always be wiping their nose. So do you need to postpone them? Would they improve further? To my judgment, this criteria may not fit well. So apart from the infant status or the purulent nasal discharge, I would agree with the rest of the criteria to postpone the child. But when in doubt, when you really cannot make a decision, it's better to do a lung ultrasound. At times, it can pick up collections in the pleural cavity. At times also can give you dynamic or static bronchograms. And if you are not competent enough to do a lung ultrasound, then of course an X-ray chest would be advisable. If the child has asthma or a history of asthma, rather than postponing the child up at that time, we could also consider doing a bedside peak expiratory flow rate and see whether it falls below 60% or does it qualify more than that. So in case the PFR is satisfactory, then maybe with cover of bronchodilators, you can still take up this child for surgery. But do not forget atopy and anaphylaxis, which means that these respiratory symptoms can also be a part of an allergic process. Hence, when you have to look at or get a history or look for atopy or allergic conditions, then you will have to look into specific complaints. The GIT complaints are generally associated with atopy, eczema, allergic asthma, allergic rhinitis, and do not forget food allergy. When you look for eczema during your examination, remember those kind of eczematous spots or areas can be found on cheeks and scalp in infants and on limbs in children above 1 year of age. Allergic asthma will generally represent as wheeze, chest infection, and you would have to do a peak expiratory flow rate in these children. Allergic rhinitis, if the patient is having, and if you are able to prove that, then they would always have an accompanying hyperreactive airway. Similarly, food allergy is often missed, and we do not take a detailed history about food. Remember, when these atopy manifestations or symptoms exist, they can have cross-sensitivity to latex, especially the gloves or the catheters which are used, and also chlorhexidine. So these kind of patients must be posted as first on the list, and this should be documented on the list that they are allergic to certain, they have a history of allergic manifestations. So if you have a doubt, always keep epinephrine loaded in hand. And second thing is, during your preoperative medication, make sure you have both H1 and H2 blockers which are prescribed to the patient. And maybe at times, if there is a positive history, do also give a steroid pre-medication. Normally, if you have to test for certain things pre-op, it's better to do a skin prick test. It's a very easy way of performing it, that you take a small liquid or a drop of the agent or pharmacological agent which you are going to use, put it on skin, and then create a skin puncture. And then look at the dermal wheel which forms around it. And if it does happen more than 5 millimeters, it will be positive. But this is generally done by a clinical immunologist. But these are readily available allergic tests which can be performed if you want to rule out any cross sensitivity which is there in the patients. Now, what about preoperative investigations? The routine investigations depend upon the nature of surgery and the ASA physical status. If the child belongs to ASA 1 and 2, no test is routinely done. However, if he is on ASA 3 and 5, then if there is a risk of AKI or acute kidney injury, you would like to do renal functions and ECG if it is not done. Similarly, for intermediate surgeries like hernia repair and adenotonsillectomies, ASA 1 and 2 patients, you may just go ahead to do hemoglobin and routine urine examination. But if it is ASA 3 and 5, it's better that we do hemoglobin, complete blood counts, coagulation profile, renal function tests, ECG in special cases. Major surgeries like scoliosis in ASA 1 and 2, you would like to do hemoglobin, full counts, and renal functions. However, if the patient belongs to ASA 3 and 5, then apart from what we are doing for ASA 1 and 2, you would also like to do coagulation profile, ECG, or an echo. Certain specialized investigations would have to be done depending upon the indications like disease, symptoms, and clinical findings. Suppose the patient is coming for a liver disease or some sort of a liver surgery, and then you would have to do those
Shilpa, what's the problem?
function test. And if the patient has a small mass which is there in the mouth, inside the mouth, such dilemmas can exist and you would have to plan it out. So this is the same child. When I happen to see this child in the ward, look at the respiratory distress the child is. He is having an oxygen cannula. Oxygen is flowing, but the saturation is just 90%, and the heart rate is about 140 beats per minute. And you can see severe indrawing which is existing in this child. So now the dilemma comes: how should you plan for an airway management if the child is posted or scheduled for excision of this oral mass? So this is the child, the same child. When you look at him when he cries, the indrawing is exaggerated. It becomes too much. And you look at the saturation, which is just 90% on oxygen inhalation. I do not know how much oxygen is actually going inside because the upper airway obstruction exists. So what we did was, I just happened to take a small endotracheal tube. I used it as a nasopharyngeal airway, put it across through the nose from the other nostril, while the Ryle's tube or the nasogastric tube was on this side of the nostril, and put oxygen just near to that T-piece. We could have even connected a T-piece to it. And following that, now you can compare how comfortable the child is. The obstruction to a great extent has been relieved just by a presence of a nasopharyngeal airway. And that dilemma of it being a difficult airway with a child having can come on some of the days when you're posted there. So this child, finally, we could intubate. What we did was we started giving oxygen and sevoflurane with the same nasopharyngeal airway. It is called something as a insufflation anesthesia. And when the child was little bit on a deeper side, then we could remove this nasopharyngeal airway and bag ventilate, and we could easily ventilate the child and then perform an endotracheal intubation. However, we could have even exchanged this for a smaller nasopharyngeal airway and then attempted the face mask ventilation. So that smaller nasopharyngeal airway was kept by my side, So if I was not able to ventilate without this, then I would have opted for that small nasopharyngeal airway, which would not stick out of the mask when I try to ventilate the child with the mask and back. So there is another child. This is another child which was posted a giant occipital meningocele. You just compress it a little bit and you look at the respiratory rate, how it goes up. A little bit of more pressure when it is allowed, it is put on, you will find that the child suddenly wakes up and goes into and becomes uncomfortable. And the moment you try to lift this big encephalocele, the child starts crying. So how are you going to intubate? How are you going to get this surgery done? So these kind of dilemmas would exist where a team approach is required, and you would have to look at alternative means of handling such a case. Now, this case would have to be given prone ventilation, prone position for them to operate, and the child is not even allowing you to lift the swelling, and that is where the problems can occur. So what we did was we just did an ultrasound for this child, and this is the opening between the dura and the mass or the occipital encephalocele. And you find when the child is discomforted and he's trying to cry, the opening widens. So it becomes more, the swelling becomes more tense. And that is the reason the child becomes more agitated. Hence, in such cases, it is better to keep the child completely sedated. So what we opted was, we just put in a small cannula with the help of an ultrasound because we could see only CSF there, no brain tissue. And we drained all the fluid which was there in that occipito-encephalocele. And you see 2 bottles are already filled and the 3rd bottle is filling up. But what we noticed here was that the rate of decompression was important. And we could monitor the child's respiratory rate. So whenever the drainage or the rate of drainage were high, the child's respiratory rate increased. So we could titrate the drainage to the child's respiratory rates to an extent that it doesn't go up. So that's the only, that was a crucial parameter which was observed while this drainage was done. And following that, the whole swelling was decompressed. We could easily place the child in prone position, intubate, and the whole procedure could be accomplished. So such dilemmas regarding management of airway would exist and would come to your focus and many times in your life. And then you have to have 3-4 people looking at the child and then taking a team or a combined decision how to go about it. And somehow someone will come up with a brilliant idea which will work very well for us. Even when you have a doubt, I would suggest if you are planning a difficult airway intervention, it's better to look at the algorithm again. Have a look at the algorithm and define where you would have your plan A, plan B, and what is your rescue plan in case if none of these 2 plans work out. So have a preoperative review of an algorithm, especially look at a child who may belong to one of the syndromes, but also make sure that whether it is a compromised versus a difficult airway. Difficult airway would be somewhere you may not be able to intubate, but it's difficult for you to put the child to sleep. And if you try to put the child to sleep, you may lose the airway. Those compromised airways have to be looked in a different way. Then a difficult airway, which can somehow be managed and you can come out whenever you wish to. So you can have a preoperative review of an algorithm, have plan A, plan B, and a rescue plan, and also have your airway difficult cart organized. Look into it 1 day before and see which kind of adjuncts to the airway you would require, and remove rest of the junk out of the trolley. I would suggest that a simulation of the team and the people who are going to be involved in that child's management can be run on a mannequin, so that everyone knows what is the task or what is the assigned role which he has to play, who has to call for help, someone who's going to record the time, someone who's going to lead the team, Every role is defined if you have a 1-day preoperative simulation done for that particular case, which you're going to do the next day. That is how simulation works. When you do it in conferences, you have people from different areas which will be forming a team just to give you some sense how simulation would help you to organize yourself. But if it has to really help you in real-time scenario on everyday basis, then this is the way it should be done. You run the simulation exercise with your team who is going to be there in the theater 1 day prior. It will help you to organize all the equipment you need, all the help you need, and everything will work by clock. And you will know when to sound alarms and to raise a red flag so that at no time patient safety is jeopardized. Difficult airway can be associated with different syndromes. The list is here. You can have it's given in most of the textbooks. You can have a look at them. So if the child belongs to one of the syndromes which are listed here, then you can anticipate that there will be some difficulty in securing the airway. Now, what about preoperative fasting? You get a good history at times from parents, but at times the parents can conceal. They would have tried to calm the child, which is crying of hunger, and some amount of some feed may have been delivered to the child. So then you're not sure what is the feeding or the fasting status. To me, to say it's a fasting concern, I would say that we should have preoperating feeding guidelines, not fasting, because fasting is something which is not palatable to children or to parents who have their children, that my child is going to now fast. Instead, if you say these are feeding guidelines, it becomes more defined and more acceptable to parents, where you can say for this many hours, you can give clear fluids. Beyond this many hours, you cannot give any milk or any other products to the child. Still, if you have a doubt, it's always good to do a ultrasound or a gastric ultrasound. You look at the antrum and you will find if it is full or it is collapsed. And if you can make it out with the help of a gastric ultrasound done on the bedside, most of your dilemmas would be answered. So this is how a child's antrum looks when it is empty. So it is completely collapsed here. Here also it is completely collapsed. And the gastric residual volume can be measured by the formula given here. Now remember, after COVID, even before COVID, there are major mental health issues. Not only with adults, it has also transgendered into the children as well. So it is imperative now that we also look at the anxiety scale of the children. So these are certain pictorial depictions which are given of children, how the anxious status could be scaled. And you can actually scale them by taking one of the boxes here. And if you find that it is the first category, then the anxiety score is nil. You do not have to really intervene. But if there are minor anxiety scales, like which see in figure 2 and 3, then some action needs to be done. So in minor scales, you will have to use a sedative pre-medication to make sure there's a comfortable separation from the parents, and distraction plans can be charted out, how you would distract the child to take the child into the theater from the pre-op holding area. In moderate anxiety, it will be important that you give sedative, and you may have to intervene by asking the parents to be able to participate during the induction time, because parental separation in some children is extremely difficult. And if the parents are educated enough and they are willing to participate, that's the more important question. Whether the parents are willing, or one of the parents is willing to participate and take the child into the theater or into a pre-operating area where you can induce the child in the parent's lap. That would be the most convenient way of managing these children who are moderately anxious. Even in children who require special needs, or they have severe anxiety, like autism, like ADHD or learning disabilities or other kind of issues, then these children would have to be taken care of by some sort of professional help which should be available for you to guide you how to manage these patients preoperatively as well as postoperatively. So a pediatrician, a child psychiatrist, a clinical psychologist or a neurologist would have to be involved in such patients. So it has now become imperative that you also look at the anxiety scale of children as a part of preoperative assessment. Especially in conditions like autism and ADHD, their likes and dislikes have to be charted out. Their coping mechanisms have to be identified. Their mindfulness, whether it is helpful or not, we have to identify. Their feeling about certain touch, noises, smells, textures, and foods have to be identified. You have to ask for a sequencing or a structure which is reassuring to them. And the response when they feel overwhelmed, do they become violent? And drugs, if they're on, like melatonin, does it work? So these are the things you will have to look into as a part of your preoperative examination if you find the child is belonging to a scale of 5 or 4. Then you would have to have trained nurse participation or parental participation. You will have to look at drug interactions and the triggers for ADHD. Vaccination and anesthesia, there is no immunological contraindication to vaccinate a healthy child undergoing anesthesia if they are scheduled to receive one. But remember, if it is an inactivated vaccine, it's better to delay surgery for 48 hours. What about common illnesses? Fever, if it is not a fever which is not there for past 24 hours and the child looks systematic, has no constitutional symptoms, we do not need to postpone. However, if the child is on antibiotics less than 1 year of age, and is having constitutional symptoms, then it is better to postpone for 2 weeks. Certain viral xanthimas like varicella, measles, mumps, and rubella, it's always wise to exceed the duration of postponement by the maximum incubation period, that is almost 6 weeks. Ear infections, again, if the child has constitutional symptoms are present and is on antibiotics, you may postpone for 4 weeks. Thank you very much. That is all I had to give you today. I'm sorry I am recording this lecture and for 1 day prior because I would be busy tomorrow with convocation in JIPMA and I may not be there live. But if you wish to ask questions to me, you can take my email ID and post those questions to me. I'll be very happy to answer. Thank you very much. Thank you, Dr. Edward.
Thank you, sir. Kannan, sir.
Thank you very much, Dr. Pankaj Kundra. And he has enumerated the dilemmas, that is, children with murmur and upper respiratory or lower respiratory infections. Sometimes we do get into difficulties how to manage this difficult airway in a newborn, because assessment of the difficult airway is not as easy as we do it in the adult. And of course, sedation and premedication is still a problem for newborn. He has also told his experience how to give sedation and whom to give, how to manage such patients, including the patients like autism and attention deficiency syndrome. Another dilemma we frequently encounter is child with fever. Because the previous day the child will not have any fever. On the day of surgery, there will be a fever at 100 or 101. And he has also nicely explained if there is any other constitutional symptoms like a feeding problem or some antibiotic dependent is likely to, in that case, you can postpone the surgery. Otherwise, a mild fever of 100 degrees without any other constitutional symptoms, you can go ahead. And I do find no doubts regarding this. And he has also kind enough to told us his phone number and email address. Any doubts or suggestions can be directly asked to him. and the audience at present, if they are free, they can give their opinions and they raise their doubts, and we have a short discussion if possible.
So there is one question, that is why urine examination in the preoperative period for the ASA 1 children?
That's true, because ASA 1, in my personal opinion, does not require any urine examination. But what Pankaj Kuntra has the answer for that, I do not know. What is your opinion, Edward?
Yes, sir. If there is not a routine examination for the pediatric patients, routine examination we will do is hemoglobin.
Yes, that's true.
So the next question is how to check airway examination in children. It is already given in the art textbook, corpus index indices. That is corpus
Yes.
indices. You have to look for the corpus indices means C means the chin, the position of the chin and opening of the mouth, uvula, P, previous history of intubation, R is range of movement of the head. So these are the copper indices. It is given in every textbook. So no more questions.
And he has also said peak inspiratory flow rate you have to measure. I do not know how a small child will cooperate for this. Any other technique? Flow rate?
Flow rate for
Children, in asthmatic children.
oh, it's difficult. He may be mentioned in the intubated patients.
Oh, even in intubated peak in yes. So yes, mentioned during the preoperative assessment of patients.
It's very difficult.
Yes.
And one more question, the practical question is vaccination, immunization, and the timing of elective surgery.
Yes.
So what do you think about this? Previously, we used to say 4 weeks for attenuated vaccines. We have to wait.
Yes.
But recent guidelines, APA, that is Association of Pediatric Anesthesiologists of Great Britain, they come out with the guidelines. We need not stop elective surgeries for live attenuated vaccines, but we have to stop 48 hours for attenuated vaccines because there will be symptoms.
Why?
Because the symptoms, there is fever, swelling, the symptoms will interfere with their perioperative diagnosis. So better to stop 48 hours. We wait for the inflammatory reactions, that is systemic reactions, fever and all, and you can take up the case after 48 hours. So this is the recent guidelines.
I am not aware of that. Right. Okay.
So 48 hours for inactivated vaccines and live attenuated vaccines, no need to wait for live vaccines. Likewise, in the immediate post-operative period also, you can give immunization. That is the new guidelines. Anything else, sir, you want to discuss with the pediatric anesthesia? You are a well experienced person. So there is a problem in your link, I think. So I thank today's speakers, Parthasarathi sir and Pankaj Gandhara sir, and our moderator, Professor Kannan sir, for wonderfully moderating this session. And with that, we come to the conclusion of this today's session. Remember, November 1 to 5, our IAC election is there. This is a great democratic process. I ask the IAC members who are participating in this program, please vote their please show your democratic right to vote in between November 1 and 5. With that, I conclude. So, Karan sir, you want to say anything? There was a link interruption.
Okay, Edward. Thank you very much. Yeah?
Thank you, sir. So next month we will come out with a more interesting topic. Meantime, I thank the Acrola and A1 Logics and also the Anaesthesia TV for cooperating with us. Thank you one and all. We will meet the next month with an interesting topic. Thank you. Thank you, sir.